This presentation is going to cover assessing the patient with an altered mental status using the acronym of AEIOU TIPS. As a reminder, A is alcohol acidosis arrhythmia, E for endocrine electrolytes encephalopathy, I for infection, O oxygen and overdose, U for uremia, T for trauma and temperature, I for insulin, P for psychiatric, and S for stroke and seizures. Beginning with A, first one, alcohol. We're all pretty familiar with those chronic alcoholic patients and everything that can go in with them of what causes that altered mental status. And truth be told, probably a lot of us have been that alcoholic patient with that altered mental status. But remember, not always is it as evident. So a lot of times if you got these patients that have just this really weird wintergreen odor on their breath, sometimes these really bad alcoholics, the typical liquor stores won't sell them anything. So they'll go to CVS and just get a bunch of mouthwash and get drunk on mouthwash because it has such a little amount of alcohol in it. It's not age restricted, so they can go and abuse those substances. In terms of acidosis, first is respiratory acidosis. So that's caused by CO2 retention. And that CO2 retention is caused by instances of hypoventilation. Now, whether that hypoventilation is caused from an overdose or from trauma, something has depleted that respiratory drive, making them hypoventilate. Or poor processes of gas exchange in such diseases like COPD, where the oxygen's getting to the alveoli, but the alveolar membrane is damaged so the gas exchange doesn't happen. So as the body metabolizes and that CO2 comes back to the alveoli to swap places on that hemoglobin with the oxygen, it can't because of the damaged alveoli. So that CO2 keeps building up, and building up. Our normal ranges of CO2 are 35 to 45, but it's very common for those chronic COPD patients to maintain in the 50s, so they can almost pretty much run on a near state of acidosis. Very, very, very mild, of course, but so in that hyperventilation, if you're holding your breath, that CO2 goes up. When you breathe really fast, you can blow off that CO2. So in other orders or disorders such as metabolic disorders, and for metabolic acidosis, such things as diabetic ketoacidosis or HHNK. With a lot of these metabolic issues, there can be a huge loss of fluids, which can transition into acidosis from, severe sweating, nausea, vomiting, diarrhea, and with that, whenever you start having poor metabolism or you've got poor oxygenation and perfusion, your body transitions from aerobic metabolism of using that oxygen, the full Krebs cycle of oxygen and glucose. It goes into anaerobic metabolism. And with that anaerobic metabolism, there are high levels of lactic acid that build up. That lactic acid can lead to renal failure, or the renal failure leads to that buildup of lactic acid. In those metabolic issues, the body uses its respiratory system as a buffering system. So in those instances of DKA, where that patient has those deep Kussmaul respirations and are breathing 30-35 times a minute. Baseline stuff, we've always been told if a patient is hyperventilating that we need to bag them down. But in these instances, they are trying to buffer their pH system. So just give them high flow O2, that'll help with the acidity, and just let them breathe and buffer themselves down. In terms of arrhythmias, treat those underlying issues. Try to treat those reversible causes and treat any kind of those EKG changes that you may find. Just going back to the basic ACLS. Endocrine disorders are mostly related to hormone disorders such as hyper or hypothyroidism. One of the big ones that's talked a lot about in there is adrenal insufficiencies. Even though it's a very rare disorder, with this, they have such a wide varying symptoms of weakness, nausea, vomiting, diarrhea. They can have skin tone changes where they become really red and flushed. They'll have excessive sweating, which can lead to electrolyte abnormalities from all that sweating, and just a wide array of things. So you can imagine if the hormone levels that control how your body responds and handles everything, if they were to go completely out of sync, it's going to just disrupt the entire body's homeostasis. In other endocrine stuff, history of diabetes. Okay, so type 1 diabetes is related big into these disorders, and they vary into that. So a lot of most diabetics are always getting their hormone levels checked to see how well it's all going, because a lot of this stuff can completely mimic a diabetic, whereas they will act like a diabetic, look just like a diabetic, but they're going to have a normal blood sugar range. Also, type 1 diabetes can lead later into those endocrine or thyroid disorders. So, and with them, they can have a large varying levels of mental status, all the way from unresponsive to mildly normal, all the way to full-on aggressive, excited deliriums, near psychosis patients. So with that, a lot of times it's a really tough thing to field diagnose, but you're going to just do comfort measures and treat any kind of reversible causes that you can find. Treating fluid disorders, blood sugar issues, whatever you can field diagnose. For encephalopathy, basically that just means that it's a brain disease, damage, or malfunction. So most generally when we see that, it's just going to be a hypertensive crisis. So a lot of the science shows that the brain's vessels can only maintain a systolic pressure of about 220. Anything over that, the patient becomes very susceptible for an aneurysm. So for those hypertensive crises, we use a beta blocker to reduce that hypertension, such as labetalol. With infection, one of the most notable ones that is talked about probably the most anymore is sepsis. So those septic patients, they've got a history, they've had some kind of wound or a surgery, something has happened to open them up to some means of infection, or it's a simple infection like a UTI or something really subtle that just went untreated, undiagnosed, it later evolves into sepsis. So with sepsis patients, they most notably all have a fever. They'll develop hypotension, tachycardia, showing that they're in shock, but a shock patient with a fever should always give it away. An infection. Infected patients have fevers. So with that fever and then the hypotension and the tachycardia comes hypocapnia. So their end-tidal CO2 levels will be low. In the pre-hospital setting, there isn't a lot to definitively diagnose sepsis other than your basic vital signs, end-tidal capnography, and about the only other thing that most pre-hospital settings that do have major sepsis protocols is they're measuring a finger lactate to see if there's any lactate levels that are increased that come from that infection. And also those non-traditional questions of asking how the urine output is. Are they peeing? Do they have any weird colors? Or are they peeing at all? Also, there is some new research going out into these septic patients that in the later signs, those later stages of sepsis, they're starting to lose that fever. The body's lost its fighting abilities, so that fever isn't developing, trying to fight off all those intruders. So treatment, fluid boluses. These patients are severely dehydrated and their blood is polluted. So the solution to pollution is dilution. So just be careful giving them fluid boluses, because a lot of times with them they can be in renal failure also. So if the renal system's not working, you don't want to overload them in fluid and end up developing major flash pulmonary edema. So treat in fluid boluses, reassessing lung sounds, and all issues of perfusion continually, and then otherwise basic supportive care. For O, oxygen's the first thing we're going to talk about. So hypoxia. Everybody's pretty familiar with what hypoxia is. So you're looking for that cyanosis around the lips, around the nail beds, the pink gums. No matter what race you are, a lot of that skin where it's pink is pink on everybody. So around the lips, the nail beds, the gums, even sometimes around the eyes, looking for those signs of cyanosis. Those dilated pupils are also common with patients who are hypoxic. And so thinking back to that first acidosis, if a patient has high levels of CO2, your pulse oximetry will be skewed. So think about that. So you put that pulse ox on these patients and you're thinking about that, oh, okay, well, their saturation says 98%, but they still look kind of cyanotic. That pulse ox is just picking up that your hemoglobin is 98% saturated with something. That might be CO or CO2. So you treat the patient, not your equipment. So treat the oxygen and any kind of pulmonary meds. If they have constriction, give them those ANAs. If they've got pulmonary edema, give them CPAP and nitrates. And controversially, Lasix is still considered in some protocols, but a lot of research isn't supporting Lasix in a pre-hospital setting. And overdoses, we're looking for those opiates. So contrary to hypoxia that it causes dilated pupils, those opiates are going to cause pinpoint pupils and respiratory depression. So in hypoxia, they're going to probably be tachypnic, trying to get in more ventilation for respirations. So they may have that complete respiratory depression or complete apnea with that opiate overdose. So those, obviously, you're treating with Narcan, intranasally, intravenously, or if you have those intramuscular injectors that some places are using. With stimulants, going to be the complete opposite. They're restless. A lot of times they have high fevers and tachycardia, and they will also have dilated pupils. So such stimulants as Molly, ecstasies, and a lot of times these people are doing combinations of opiates and stimulants and what's known on the street as a speedball. So they'll inject these opiates until they can feel themselves about to pass out, and then they'll take a bump of cocaine or something and then wake themselves wide open. So they'll go from one extreme to the next with those speedballs. So in that same thing, coke, oxys, or not oxys, but mollies, they get really wound up. And with that, something that's seen in the areas a lot is oxys, sorry, not oxys, but ecstasy and mollies getting taken together, and they will cause these patients to become hyperthermic. So that just kind of makes a whole larger cascade and all this stuff. So with them, Narcan's not going to do anything for them. The best thing to do is treat them with sedatives. If they start getting in these excited states, or they're developing tachycardia, or they're seizing because of all the side effects of that stimulant. So let's just do an overview of the entire overdose and poisoning protocol for West Virginia. So knowing the route, so ingest the poisons, big consideration is going to be the airways, protecting that airway. Never induce vomiting. So those old theories of the ipecac syrup and whatnot, we're not going to do that. There's possibly a chemical reaction going on in the stomach now, and the last thing we want to do is to move that chemical reaction all the way from the stomach all the way up. Transport the patient with the containers, bottles, labels from whatever you can find, or pictures of if you don't feel it's safe to take that in an ambulance. Open, broken containers. Think sensibly, but take pictures of them. At least write down what you need to. Inhaled poisons, remove them from that hazardous environment if you can safely be in that environment. If it's a hazmat scene, don't put yourself in there. Let the hazmat technicians bring the patient to you. Since it is inhalation, airway is always a consideration. Looking in there, looking for any kind of nasal burns, any darkening of the airway, the pharynx issues. Just think if maybe you're going to have any kind of worries about inflammation if you need to maintain that airway aggressively. And again, anything you can safely transport with you, take it with you. Absorb poisons, remove the poison using procedures in the burn protocols. So if there's something powdery on them, brush it off of them. Mostly everything else in there, the solution to pollution is dilution. So anything that's absorbed in there, brush off the big stuff, heavily dilute them, have them be decontaminated before you transport them. Anything injected, if they've shot up a bunch of heroin, take the needle out. If there's anything still stuck in them that you can safely remove, do so. But don't get these patients decontaminated if it is something severe. So knowing what they were exposed to, when, the whole duration it was, the concentration of it, any kind of actions that were taken, if they took anything beforehand. Did this person drink half a gallon of milk before they called 911, or did they actually call poison control and do the right thing? So with overdose of alcohol, these patients can go into withdrawal and DTs, those delirium tremens. So they could go into full-on, nearly excited deliriums, have full-on psychosis, completely altered from the alcohol withdrawal. Assess circulation and try to rule out all the BLS stuff. Don't skip out on checking the blood sugar because they're an alcoholic. A lot of those alcoholics will end up going into diabetes, so they can be in a hypermetabolic state, burn off all their glucose, further cascading that altered mental status. So check out blood sugar, check them for signs and symptoms of shock. If they're in seizures because of the DT, treat for seizures. The same thing you do. If they're in severe agitation, if they're having major tachycardia, hypertension, just hallucinating, major psychotic issues after that, because most psychotic issues lead to tachycardia and hypertension, sedate them with Versed, 2 milligrams or 5 intranasally. If they're over 55, give them half a dose of 1 milligram or 5 intranasally. For narcotics and opiates, maintaining an airway, always a big thing with everybody. Checking the blood sugar. If you know that it's opiates, they're in respiratory depression, which is the number one reason why we want to give Narcan, is because they're not breathing. We don't want to bag them or intubate them the whole way to the hospital when we can easily fix that. So give them Narcan up to 2 milligrams IV. Start at 0.4, give slowly. As much as the movie Bringing Out the Dead made it look awesome with slamming a Narcan and they stand straight up, don't do that. That quick reversal of that overdose can end up leading to a lot of other major side effects. And also, if you go slow, you're a lot less likely to have the patient come back be combative. And on that same note, there's a lot of research that goes into the fact that a lot of these patients that are overdoses, they get resuscitated essentially with Narcan. The reason they're so altered is because they got so focused on giving Narcan, they didn't get ventilated. So that patient wakes up with a hypoxic brain. So we know that hypoxia causes an altered mental status. So you think if this patient isn't getting ventilated when they're apneic, that all of a sudden are going to be awake now and are going to be hypoxic and very altered, it can be combative. If you can't get an IV, 2 milligrams intranasally. It's a lot more safer than going intramuscularly. If we're on TCAs, with that they're going to have serious signs and symptoms, altered mental status, sustained tachycardia, and possibly a widened QRS and hypotension. Give them fluid boluses. Same way you would find generally anybody who's hypotensive and mildly tachycardic. Give them fluid boluses. So some common TCAs you might see is Elavil, Sinequin, Trofenalil. So on the chlorogenics, support those respiratory, support their airway. With all stuff, overdoses, the number one thing we're worried about is airway, always. So there's chlorogenics, like organophosphates, we're looking for that sludge acronym. Okay, so they're going to be bradycardic, and you're looking for that salivation, lacrimation, they're crying, that urination, they pee themselves, defecation, they poop themselves, GI issues, they got an upset stomach, and emesis, vomiting. And so they're going to be bradycardic, and you give 2 milligrams of atropine IV. Repeat every 5 minutes as you need to restore that normal heart rate. You're going to mostly see those organophosphates around farmland, USA. Calcium channel blockers, If they have bradycardia and hypotension, give them atropine, 1 milligram IV. If you know, definitely that's what it is. But most of the time we're going to find those patients altered in bradycardia with unknown reasons. Beta blockers. If they're bradycardic with hypotension, give a fluid bolus. If you can definitively say that it was a beta blocker overdose, give up to 2 milligrams IV of glucagon. Repeat that dose in 10 minutes. But do a quick inventory on how much glucagon you have. So give 1 milligram. If you only got 2, try 1 milligram, and then if it doesn't work after 10 minutes, give another dose. With stimulants, say a patient just did a whole bunch of cocaine, and now they got serious signs and symptoms of seizures, tachydysrhythmias, over 120. 2 milligrams of Versed, a slow IV push, titrate to effect. So go slow, try to get them relaxed, get the heart rate down, get their excited stuff down. With cyanide, if you have the cyano kit, infuse that over 15 minutes. Pediatric dose on that is 70 per kilo. Not many people are carrying those anymore, but just a consideration. And if you carry the hydroxycobalamin, I cannot pronounce that. If you carry that, which I'm not really sure if anybody ever does, just reconstitute that with normal saline and follow the instructions on that packaging for that cyanide poisoning. Stop it. With uremia, basically in renal failure, there is an excessive amount of waste products in the urine. So that's the job of the renal system, is to go in, filter out all our blood, help maintain our pH. So that our renal system is basically just like that wastewater treatment plant. So you can imagine how dirty that water could be coming in your house if the water treatment plant wasn't there. So pretty much whatever you flush down that toilet is going to come back through your sink. So let that sink in. So when that, pun intended, so when that water comes back through that sink, if it's not getting filtered out, it's going to look nasty and dirty. So the same thing in the body. When that waste is going out, what we're peeing out is going to be dark and nasty looking. So rhabdos, mostly common in the geriatric population, but it's also really common in the athletic world. So a lot of these extreme athletes, these big crossfitters, marathon runners, these people doing extreme body movements over extreme amounts of time, just completely exerting themselves, doing some of the craziest fitness things you could ever imagine, can end up developing rhabdo. So they'll have crazy abdominal pain, peeing really dark, almost brown urine, and with that they can end up developing hyperkalemia. So those peak T waves, see those peak T waves developing that. And also you got that patient who is in complete renal failure and is skipping their dialysis appointments, is also going to develop those same things. So treating that, small fluid boluses. So they can need large amounts of fluid, but since they're in renal failure, be careful giving large boluses because they're not going to have a buffer or filter system, and you can cause flash pulmonary edema. And then treat any of those ECG changes that you see, like with hyperkalemia, given some bicarb, or if you're able to, calcium gluconate. In the traumatic patient, if we see they have an altered mental status, generally the number one thing that comes to our mind is head injuries. And generally we can't ever rule those out in the field in the major trauma patient with an altered mental status. So we're looking for those things of head injuries such as hypertension, unequal pupils or pupillary changes or neurological deficits. So that Cushing's reflex of hypertension, bradycardia, dilated pupils, and then posturing. Also, we're looking for stages of shock. Shock is simply hypoperfusion. So if your brain and your whole body is hypoperfusing, that's not going to be enough oxygen and enough blood flow nutrients to your brain to make it function as it needs to. So yeah, they could have a head injury and still be hypoperfusing and just have a concoction of traumatic illnesses. So remember, in shock, with that hypoperfusion, you're looking for tachycardia and tachypnea first. Those are your early signs. That's your first stages of compensating. Hypotension is a late sign. That's when your body is decompensating. It's lost its ability to compensate for adequate perfusion. But things that can skew those normal vital signs is energenic shock. Those affective and or afferent and efferent receptors, the signal's cut. So those sympathetic responses to increase that heart rate and cause vasoconstriction, those are gone. So you just become hypotensive with a regular heart rate and looking for those skin tone changes. Also in beta blockers. So this patient with beta blockers, her body doesn't have that ability to compensate perfusion issues by increasing that heart rate because of that beta blocker. Heart rate tries to increase, the beta blocker prohibits that. Also, there's more research going into, since the drug epidemic is becoming so big, that a lot of these druggies are now getting in traumatic injuries. And a lot of times, since they are so depressed, not psychologically depressed, but just everything else depressed, their sympathetic response is down. So that's why they're just slow, lethargic, basically couch potatoes sometimes. That sympathetic response doesn't kick in to allow that tachycardia and whatnot to happen. So if they're on any kind of these things that normally sedate a patient, a lot of times you can see the vital signs aren't correlating to what a typical shock patient does. Now, in terms of temperature is going to affect the metabolism. So if the metabolism is either sped up crazy fast or slowed down too much, Goldilocks isn't happy. So this homeostasis is completely disrupted. So in hyperthermia, that could relate to that widespread infection or be related to those overdoses, but it just took a bunch of ecstasy and mollies and they're hypothermic, and now they just got a concoction of other things. So the hyperthermia, they can lose a lot of their fluid. They can have major electrolyte abnormalities, and just the whole process of metabolism is disrupted. And the same with hypothermia. So hypothermia can end up causing vasoconstriction, which can cause hypoperfusion, and just a variety of other things. And so remember, with those hypothermic patients, since it is a metabolic issue essentially, withhold those cardiac medications for core temperatures, sticking that thermometer up the rectum. If it's less than 86 degrees, withhold those cardiac meds, because all the science shows that if they're hypothermic, that medicine won't metabolize and it won't have any kind of effect. So in the event of cardiac arrest, just do CPR, because we know they're not dead until they're warm and dead. The next I is insulin. So even though we've talked about some endocrine disorders, I focuses on insulin issues. So most notably the diabetic. So that type 1 diabetic mostly is insulin dependent diabetes. So the high side of that is DKA. Those type 1 diabetics go into DKA. The type 2 diabetics who can balance and maintain their diabetes with medications and or diet, on the really high side of that, go into HHNK. They're not really developing those ketones. They don't have that fruity odor on their breath or anything like that. So if they go low, our treatment is going to be 25 grams of D50. If you can't get an IV, give 1 milligram of glucagon intramuscularly. And also to consider, if they do have other underlying issues like malnutrition, you want to give that thiamine first. because say the chronic alcoholic, they ingest so much alcohol their body isn't producing thiamine anymore. So if you just load their body up on high levels of glucose, it can cause some encephalopathy and other issues on their brain because of it's not going to be able to absorb that glucose very well. So we'll do a quick review here on some West Virginia protocols. For that patient 1 month of age or younger, they need D10. So that's prepared by mixing 40 mLs of normal saline with 10 mLs of D50. So D10, you take 10 of D50 and then mix up that 50 cc syringe again. In the patient that's older than 1 month but younger than 2, you're going to do D25. So you basically take the D50 and then mix it half and half. So D25, take 25 of D50 and fill the other 25 back up with normal saline. Over the age of 2, with a blood glucose less than 60, you're going to go to D50. Maximum dose of 25 grams, which is a whole ampule. Then if there's no IV available, administer that glucagon. If they're under 20 kilos, give half the dose, 0.5 milligrams intramuscularly. Over 20 kilograms, the full dose, 1 milligram intramuscularly. With psychiatric, one thing to remember that it may not truly be an altered mental status. Remember, that is very subjective to us. So what is abnormal to us may actually truly be normal for them. So you need to understand what their baseline always is. That GCS of 446 or worse might be the best they're ever going to be for the rest of their life. So some things can go into that is more geriatric issues of Alzheimer's and dementia, or as we see in the field, those sometimers or the sundowners, as a lot of these people are saying. So they've just got major brain disorders that are just at that point that are irreversible and kind of essentially almost unexplainable by science. Then more into the true psychiatric emergencies of schizophrenia, excited deliriums, where these people are having these grand hallucinatory things. So just don't try to jump in and abide, or not abide, but contribute to their hallucinations. Don't aid them and tell them that yes, there are several monkeys in the tree that are trying to attack them. Just try to keep safe, try to remain with them, and get them to the appropriate facility that can help them with their psychosis. Kind of treatment, mostly just comfort measures. If they do become extremely agitated to the point where they're dangerous to you or themselves, that's where they're going to start to need to become sedated, or you may have to go into the use of chemical restraints. So let's review that just a little bit. In the West Virginia protocol for chemical restraints, you're going to go with Versed as your first line. That's 5 milligrams intramuscually or intranasally. If they're over the age of 55, you're going to cut that dose to 2 milligrams IV or IM, but still same to 5 milligrams intranasally. That intranasally metabolizes and processes a lot slower, so generally a lot less of side effects with that. If you can, try to get vital signs on them the best you can to ensure that they're not altered because they're hypotensive, and then when you slam with a bunch of Versed, they become really hypotensive. If they continue to stay agitated, you're going to get, after 5 minutes, you're going to go to Haldol, because within that 5 minutes, that Versed should most definitely kicked in. Remember, IV is fast, IM's not quite as fast, and intranasally's slower than that. So with a Haldol, give 5 milligrams intramuscularly. So in theory, with these patients, if they're to the point where they're so severe, I'm not sure how you're going to be able to get an IV on them anyway. So if you can get an IV on them, are they really that confrontational, that much of a threat if you can stabilize them that well? So in theory, probably most of your medicines in your route with this should be intramuscular anyways. So at 5 milligrams of Haldol intramuscularly. Haldol is rarely seen to cause dystonic reactions, and with that dystonic reaction, they've just got weird body movements and contouring and almost like posturing. So if you see any of these kind of weird movements or where it looks like they've just got complete muscle spasms and cramping, give them 25 milligrams of Benadryl, either IV or IM. But again, you're probably down the route of intramuscular here. If it is a full-on excited delirium, like you've seen the news from these patients taking Flocka, bath salts, where they are just in extremist states, extreme psychosis, you're going to go with ketamine. 5 milligrams per kilogram intramuscularly, or if you've somehow gotten an IV, 2 milligrams per kilogram. Okay. Now just be very, very careful with this, because ketamine is going to make the patient more than likely quit breathing, especially at this dose. Most of the research goes into it, and patients given this dose in the ED setting, about 40 to 50% of those patients get intubated. So in the field, yeah, more likely you're going to have to bag this patient, but at least you and the patient will hopefully be safe. If there is any suspicion of other benzos in the system, consider using a half dose of that ketamine, or you're most definitely going to cause respiratory depression. And lastly, S. So let's talk about seizures. The generalized kind of seizure we most routinely see in the field is that tonic-clonic seizure. That tonic is the flexion and extension of the extremities, and that clonic is the jerking motion. So they can become stiff and then jerking, or one or the other. And with that, most generally always they are unconscious. Very rarely are there any case studies of those patients becoming tonic-clonic and definitively knowing that they still have a base level of consciousness. Now with focal seizures, that's going to be more of a local clonic movement, where that patient's going to remain conscious and their arm might just be having that clonic, that jerking motion, and they just don't know why. Or it could even be, any kind of extremity or any kind of single muscle group, almost like a super severe muscle spasm. There's other little ones that go into that are a lot less common, but most generally this is what you're going to see. So treatment of those, benzos and sedatives for those crazy ones. Okay. So in the protocols, if a seizure is lasting longer than 5 minutes, or they have 2 or more episodes of seizure activity in which the patient does not regain consciousness, which by textbook definition is status epilepticus, if they're in that state of status epilepticus, you need to give them benzos, because in this process they're probably going to get to the point where they're going to quit breathing or have some major irreversible side effects. So give them 2 milligrams IV, IO, IM, or give them more if you're going to give it atomized intranasally. If they're over the age of 55, going to cut that down a little bit less. Still keep it at 5 via atomizer, but you're going to get a half dose of 1 milligram every other route. Now, for stroke, the most common pre-hospital assessment is that Cincinnati pre-hospital stroke scale. So the little mnemonic to remember is go fast. Always check out glucose, because those hypoglycemic patients can most definitely mimic a stroke, and they can be positive Cincinnati pre-hospital stroke scale. Know the onset. The facilities need to know that to determine their level of treatment and interventions. And then you're looking for that facial droop, looking for the arm drift. Have them hold their hands up, act like they're flying like Superman, and see with their eyes closed and see if that arm drifts. You're checking for their speech. Is it slurred? Is it abnormal? And knowing in that, is this their normal? Do they have a history of stroke and they always have facial droop and slurred speech? And then consider time. So you've got your onset of how long since their last known normal, but with time, do you need to go by ground or do you need to go by air? Because with these patients, there's a very small time window before they can reverse those everlasting effects. Thanks for watching this. Hopefully you're able to understand or maybe have just a simple refresher on the AEIOU and tips. So remember, all those interventions are great, but truly Assessments is what saves lives. Thank you.